Hello, I'm Dr. Richard Mackool, and I'd like to welcome you to Mackool Online 3D CME, featuring the first online 3D videos of any medical procedure. As I perform phacoemulsification, a surgical display screen indicates the real-time foot pedal position, ultrasonic power, and both flow and vacuum levels as they vary during various surgical maneuvers. Experimenting with these parameters in a laboratory setting and thereby gaining familiarity with equipment functions and audible signals can greatly shorten the learning curve. It's my sincere hope and belief that observing procedures in 3 dimensions will be of great benefit to my colleagues. We all share the same goal: to do everything that we can to maximize the safety and efficiency of the procedures we perform, and thereby provide our patients with their best possible vision. So this patient has an obvious posterior subcapsular cataract. Our plan is to put a multifocal toric lens in here, but we want to first mark the axis, which is 97 degrees, shown on the toric axis marker. So this is a right eye, so I'm aligning the 90-degree mark inferiorly and the handle superiorly, and you can see the 2 horizontal blades lining up with the marks there. So that's now our 97-degree axis. So we're going to begin with a side port blade, and this is directed right at the center of the pupil in most eyes. If the chamber is shallow, then not so steep. And maybe make it a little bigger like that, depending on whether you're using a chopper with a ball on the end or a spatula. A spatula, you don't have to make it any bigger. And it'll make about a 1 millimeter external and about a 4/10 of a millimeter internal opening. Now comes our 2.4 millimeter typical incision, which is 2 millimeters long. The line shows you that, 2 millimeters. And then we dimple down, as we say, and then wiggle to go in slowly. Next, advise the patient that they're going to feel some stinging if you're doing it under topical, and you might feel some stinging here. A little intraocular lidocaine. And the next step is to inject the viscoelastic. And most surgeons probably use a viscoelastic such as Viscoat, a so-called dispersive viscoelastic, to coat the endothelium. And that's followed by the cohesive viscoelastic, hyaluronic acid based. And before you go in, you might want to inject just a little to make sure there are no air bubbles. And then you go in. More about air bubbles in a minute. So then we'll just cut the center of the capsule like so. You can even separate the tear. And now it's time for the capsulorhexis. And now we get to our first discussion of principles of phaco, or surgery of any kind, and that's to stabilize the position of the eye. So the spatula is holding this eye where I want it to be, and it can't really move as I do this capsulorhexis. So we start out on the rhexis, head out as far as we want to be, and now we make the turn, because that is the distance that I would like this capsulorhexis to extend from the center of the eye, and then we follow the pupillary margin. And all the time we're holding the eye still with our second instrument. Okay, so now I'll just move the microscope just a little bit to stay in good view, because that's our second principle, which is visualization. Now right there, I don't really see that rhexis margin so well, so what would I do to increase visualization? I'll inject more viscoelastic. And I'll take that cortex that's kind of obscuring my view and move it. And now, those of you watching in 3D can see the chamber also deepened. Now, I've got a really good view of the capsulorhexis there again. And wet the cornea. Fine. So I can go right down to that advancing edge, grab the capsule, and continue on with the capsulorhexis. Okay, so that's a slow motion capsulorhexis, but we were able to demonstrate two principles there. One of stabilization and two visualization. And those are the two basic principles of any surgical procedure. Next, we're going to do hydrodissection using a flat 23 gauge cannula. You notice how in 3D, again, you get to see this better. 2D, you kind of have to imagine it. How I go underneath the capsule and then lift up and then inject. The nucleus comes forward and push it back down. Now, if you want verification that it's loose, you can rotate it. If the lens is soft, it may not be so easy to rotate it. And this patient is only 54 years old, so this cannula may dig into it as opposed to rotating it. I think you could see that it rotated a little bit there. I normally don't rotate them because I know they're loose. And next comes viscodissection. And we want to do that under the capsule for at least 180 degrees. If there's any suspicion of zonular laxity, we do it for 360. And that's done with viscode. And the purpose of that is to expand the capsular fornix. The next step is to take the Phaco handpiece, point it toward the ceiling with the sleeve intact, and step on the pedal to get any air bubbles that might be in there out. Well, what do you know? There were some. If I didn't do that when I went in the eye, I probably would have introduced those bubbles. Okay, next we remove the cap. I'm obviously a right-handed surgeon. Holding the Phaco handpiece, there's an infusion line on the outside. You can use that to put your thumb on, under, or even above if you like. And the nice thing about that is it makes it easier to rotate the instrument. The second thing is to hold instruments short. The longer you hold them, the less control you have on the tip, and a little motion, the tip moves more than if you hold it short. Okay? Same thing with the second instrument. And now a little more about stabilization. Typically, you'll use 3 fingers, the thumb and the 2 adjacent fingers, to hold the instruments. The other 2 fingers go down like so. And then, when you lower your hands, you're very stable. These 2 fingers hold it very stable. And the other 3 can do just about anything. Rotate, up, down, and hold the instruments short. Notice how the second instrument, my 3rd finger is so far down, it would almost get in the field, but it doesn't. Okay? That's a very precise instrument for chopping and moving things around. This one goes out to the periphery, but I like to have that 3rd finger way down on the handle, as you see there. And next, test infusion capacity and sleeve position. Good infusion coming out of each side. If I didn't like it, I'd rotate this sleeve and get better infusion capacity, but it's good all the way here. So now we're ready to proceed with our insertion of instruments. Now here I've got a chopper in my left hand. I've stabilized the eye, and I can just insert without touching the incision. And now I'm going to go to a high flow and vacuum setting. So let's go to quadrant removal. And I'm going to use that high flow and vacuum setting to remove Cortex, so I can actually get a better view, visualization again, of the nucleus. Okay, so now we'll go back to sculpt, which is our lower flow and vacuum settings. And I focus to have good visualization. And if I were doing a divide and conquer technique, I would sculpt a trough in linear fashion, focusing down what the cornea please, as I do so. Now, if when doing this I wanted to stabilize the nucleus, I would put the spatula right there and hold it still. So, and if I did that in each quadrant, that would be divide and conquer. And then I could put my instruments in there and divide the nucleus as I just did right there. But if I wanted to do Phaco chop, which is my favorite, I would be using this chopper. And the chopper would go out over the equator and be tilted downward, and I would chop it like that. And then two-handed rotation, chopper on sculpted wall, under the capsule, verticalized, meaning pointed downward, and the chop performed. Now, see this little segment here? I'm on low flow and vacuum, and I was able to remove it. If I weren't, I would just increase the flow and vacuum level, as we'll see in a moment. Okay, so let's complete the chopping. Wet the cornea. You can see we're here in the northeast and the air is dry, so we have to wet the cornea quite a lot. And now we can go to quadrant removal. And you can see the flow and vacuum settings, how they've about doubled. And with high vacuum, I may actually be able to aspirate the rest of this nucleus in this 54-year-old patient. And so far I have. So let's now rotate this next segment and attract it with high flow. Notice I didn't actually go to touch it. I didn't have to. These 2 or 3 nuclear segments are competing with each other to get to the phaco tip because the flow is high. And once it gets there, the vacuum goes up and removes it. So the only ultrasound we really used there was to do that sculpting so I could demonstrate to you divide and conquer. Yes, there's a little piece of nucleus there, but that'll be easy to aspirate with irrigation aspiration in just a minute. The next step is to insert the INA tip. So testing infusion, it's good. This is a 90-degree INA tip with a 0.25 port. There are many different INA tips with different curvatures. Some of them are straight, some of them are 45 degree, but the principle is the same. Put the port against the cortex and then step on the pedal. That way you know what's going in the cortex. Now sometimes, not in this case, and there's that nuclear segment that we just aspirated, wet the cornea. Sometimes the posterior capsule is more forward than others, and that's when you put a spatula there. And again, those of you in 3D can see this. Put the spatula right against the posterior capsule. And now the posterior capsule just can't come up and be aspirated. Okay, final step, with an INA at least, is to remove epithelium from under the anterior capsule. And you can see the vacuum levels that I achieve and the flow levels. They're relatively low, and that's because I don't fully depress the foot pedal. But you can set this in the machine as your vacuuming setting. Okay, next we're going to inject the viscoelastic and clear the posterior capsule of the remaining opacities. So here comes the OVD injection. The posterior capsule will go more posterior, and as it does, I'll follow it down and then gently inject and rub that posterior capsule as necessary to remove the opacities. And that's all you have to do. But do this always while injecting. We're now ready for intraocular lens insertion. Stabilization of the globe with the left hand. Partial insertion into the tunnel. And this is a Monarch D as in David cartridge. Wet the cornea, please. Watch how those stria become less obvious when the cornea is wet. Good. Improving visualization. And now we inject the intraocular lens directly into the capsular sac. we use the spatula that I was palming in my left hand to insert the IOL into the sac fully before it fully opens. That makes it easier to do that. And then typically, we know that these 3 marks are the axis that we want the IOL to be aligned with. We use that haptic optic junction to rotate the intraocular lens. And now we're going to leave it shy of the final desired resting place while we remove the OVD from behind the IOL. Very important step to prevent IOP spike, but also with toric IOLs to prevent undesired rotation. So we're just going to nudge the IOL in that direction so we can then slip underneath it, rotate the 90-degree tip. Please keep looking straight ahead at the light. Very good. And remove the OVD from behind. Once that's done, we can slip into the anterior chamber and remove the OVD from in front. And then lastly, keeping the INA tip in the eye to maintain intraocular pressure, we're going to rotate the intraocular lens into the final resting position to treat the astigmatic component of the refractive error. And a little advanced, but worth mentioning, if you can't get the marks right on the corneal marks, leave them parallel to it. And here we're almost perfectly on them. I think we rotated another degree or 2 really, and that's it. There we go. Okay, so now it remains for us to do stromal hydration. So by going side to side, we deepen the chamber, hydrate each side of the primary incision. Think of the cornea as a sponge, and if you hydrate it, it swells. And if it swells, it seals the incision. And then go around the edges of the anterior chamber and irrigate the angle so you get the viscoelastic out that you just saw come out of the angle, and thereby really reduce your chances of a pressure spike. Do the same stromal hydration over here. And finally, we're going to go back and depress the intraocular lens fully into the capsular sac. It's there. That's good. It's aligned. IOP tested with a glove that's loose fitting, so I can actually feel the intraocular pressure. And if I do this several times, I can tell if it's changing, and it isn't significantly. And then, especially early experience, you'll test your incisions and make sure that they're not leaking. And you can see how dry that one is. And you'll do the same on the side port, and that's dry also. So the procedure is now completed.